Good evening, viewers. My name is Rahul Desai, and I hereby welcome you all to session number 4 of Diabetes Essentials with Dr. Sanjay Kalrasa. Dear viewers, these online modules are an educational initiative from NASAL Zero and in memory of Dr. K.K. Agarwal sir. India has the highest, second largest number of people with diabetes. The ICMR India study shows that diabetes is no longer disease of old people, rich people, or an urban phenomenon. It affects the lower socioeconomic strata as well, and rural prevalence in diabetes also increasing rapidly. Therefore, viewers, optimal management of type 2 diabetes requires treatment of ABCs of diabetes, that is A1C, blood pressure, and cholesterol. So, before I hand over the platform to Dr. Kalra sir to take us through today's important module, let me have the opportunity of announcing the names of those doctors who have answered the quiz question correctly declared in last episode. And the names are Dr. Manu Sharma, Dr. Rajiv Handa from Delhi, Dr. Apurva Biswas, Dr. Ajit Kumar Hegde, Dr. Apurva Biswas from Jharkhand, Dr. Ajit Kumar Hegde from Karnataka. From Maharashtra, we have Dr. Hitesh Vora, Dr. Girish Gesota, Dr. Vani Ganpati. From Punjab, we have Dr. Sanjeev Puri. From Uttar Pradesh, we have Dr. Ashwini Kumar and Dr. Surjit Kalsi. So, congratulations to the winners. And dear viewers, on 15th of April, we had a bigger event where Dr. Vivian Fonseca had addressed the audience on scientific approach in improving the vascular and metabolic health in diabetes. If any of the viewers wants to rewatch the session again, it is available on the same platform on the MedTalks, which we are viewing now. So with this, I hereby hand over the platform to Dr. Kalra sir to address the audience on today's module. Sir, over to you.
Thank you, Rahul, and good evening, friends. It's always a pleasure being with you. And now, for the past 1 year, let us remember something happy today, that is Mother's Day. But let us also remember that on the 18th of May last year, we lost someone very close to us, and that was Dr. K.K. Agarwal, sir. I remember Dr. K.K. Agarwal, we all remember him, and we pay our homage to him. What we are doing today, the fact that we are meeting each other today, this is part of the legacy that he has left. And as he said, the show must go on. The show must never stop. I've spent 1 year with you now, nearly 1 year, and these Sunday meetings have become part and parcel of my life. I really look forward to being with you every Sunday evening. And apart from all the people whom you meet, Mr. Anand Basu, Rahul Desai from FDC, there are other people. Shailender is there from FDC. They do a lot of hard work in managing these programs for us. We have a team from KK Med Talks, IJCP group. This is the group that was set up by Dr. KK Agarwal sir. And Pooja and Tanuja, these are two people whom I'd like to call out. They also help me a lot in preparing our topics for today. Someone at backstage is Pratik. Pratik lives in Mumbai and he handles our technical desk for us. And Pratik pointed out to me that I should shave regularly. So today here I am, shaved and ready for this talk. We'll talk today about uh, glycemic targets and how to reach them, how to fulfill them. Uh, Pratik or Rahul, can you confirm that the slides are visible? The first one. We'll talk today about how to meet targets in diabetes. Now, when you're managing diabetes, you have to have a target. Once you have a target in place, a destination, then you decide your techniques, your tools. How will you reach that target? You also have to have thresholds in place. A threshold means when will I initiate a particular intervention? When will I intensify my interventions? When will I interchange? Why will I interchange? Will I interchange because of lack of efficacy, lack of safety, lack of tolerability? So all these things come to our mind. You have to have a threshold to begin. You also have to have a target to achieve. From the threshold to the target, you need tools, you need techniques. These tools and techniques can be diagnostics, they can be therapeutics, and they can also be psychosocial interventions. Simple support, supporting your patient, that is also a technique. During all this time, another T comes, that is troubleshooting. Troubleshooting is required in diabetes care because you will see that diabetes, the glucose profile is never straight. It's always going up and down. But that is part and parcel of life. Life is different for us every minute, every moment. But still, once we have this in mind, then it becomes easier for us to plan our therapy. We also have to explain to our patients. You will find many Indian patients who tend to view diabetes as an acute disease. So we have to slowly, we have to tell them that diabetes is a chronic disease. We will live with diabetes, but we can live in a healthy way with diabetes. And to do that, we need to uh, assess glucose control. The gold standard is HbA1c. Ideally, done every 3 months. But if you have someone who is stable, where no change in therapy is required, you can even do it twice a year. So in type 1 diabetes, everyone should get it at 3 months. In type 2 diabetes, most people should get HbA1c at 3 months. But some stable people, where tight control is not required, they can get HbA1c just twice a year. Many times in my OPD, I advise HbA1c once a month or once in 6 weeks. Now, why do I do that and when do I do that? The HbA1c number is weighted in such a way that 50% of the HbA1c comes from the glucose control over the past 28 days. So HbA1c is a fair idea of for me to check how glucose control was over the past 28 days. When do I do these tests? Number one, pregnancy. Number two, if the HbA1c was very high, let us say 11, 12, 14, it comes down very fast also, like it is quite easy to come down from 14 to 10. It is relatively difficult to come down from 8 to 7. So we do it after 6 weeks. Uh, Number one, to motivate the patient, to make the patient feel happy. Number two, to make sure that we are on the right path. Supposing patient came in with HbA1c 14, the textbook tells me to give insulin, but patient didn't have too many symptoms. And patient swears that, sir, I never had diabetes. 3 months ago, I did get my glucose checked. I got my cataract surgery done also, and I did not have diabetes. Now, it might have come suddenly. So if it comes suddenly, it will go away suddenly as well. So then again, I will check. If patient promises to change his or her lifestyle totally, to introduce Minte-Morlo reforms in his or her lifestyle. So earlier patient was following a very unhealthy lifestyle. Now patient actually moves to a healthy lifestyle. Then again, the control will be fast. So at 6 weeks, I can check. So HbA1c based upon the patient's needs, you might want to do every 4 or 6 weeks in few situations, mostly in 3 monthly and sometimes 6 monthly. HbA1c is like a still frame. Every 3 months, you get a still picture. But if you want a continuous motion film, then you have to check glucose more regularly. So this can be done by continuous glucose monitoring and also by ambulatory glucose monitoring. Continuous glucose monitoring, they will apply a sensor which will last for about 5 days and it will check interstitial glucose levels. This can be done in pregnancy. It can be done in indoor patients. It can be done in patients who are very sick, in those who require really tight glucose control, in those who are at high risk of hypoglycemia. What is used across the country and is becoming more and more popular is ambulatory glucose monitoring. Continuous glucose monitoring in general in India is used more frequently by people with type 1 diabetes and with pregnancy associated diabetes. Ambulatory glucose monitoring, on the other hand, is relatively economical, easy to use. Uh, you can use a meter which is read by the physician or by the patient himself or herself. And here you apply a sensor over the arm. It will last for 14 days. It will check glucose every 15 minutes. Interstitial levels will be checked. And after 14 minutes, or even on a regular basis from 2 days onwards, you will get very good graphical pictures, which will tell you how glucose levels are behaving. Ambulatory glucose monitoring is used by people with both type 1 and type 2 diabetes. You can also use it in young children, though sometimes the children are a bit naughty and they remove the sensor. And it can be used in pregnancy as well, off label. If you do CGM or AGM, continuous or ambulatory glucose monitoring, you can also measure time in range. So you can see what percentage of the time patient had severe hypoglycemia or severe hyperglycemia or euglycemia. If this is not available, we can just do glucose monitoring. Some of our patients prefer SMBG, self-monitoring of blood glucose. Others prefer lab-based glucose monitoring. The lab-based glucose monitoring can be venous or capillary. So patient can come into your clinic and get a glucose done by getting a prick. It would be a good idea to go for structured glucose monitoring here. So pre-meal and post-meal both. Depending upon the treatment that you have given to your patient, you know your target. Are you focusing on fasting or postprandial or both? Based upon whatever you are focusing on, whatever drug is being given, you will do the monitoring. For example, with metformin, it would make sense to monitor fasting glucose. With glimepiride, glycoside, repaglinide, we would want to monitor postprandial glucose. In insulins, if you are giving basal insulin, check the fasting glucose first. If you are giving a bolus insulin, then we will do pre-meal and post-meal both and see the excursion. So these are some simple ways of working. Now, one challenge I have seen in my OPD is that when I get an HbA1c done, and let us say it comes as 8 or 9, for me, that is a very heavy number, a huge number, because how I calculate is my target is maybe 7. So 9 minus 7 is equal to 2. 2 divided by 7. Now, I'm hard pressed to find that. That is about 30%. So I feel that the glucose is increased by 30%. That is not acceptable. But for some of my patients who are not so numerate, they may be literate, but they are not numerate. They will say, Daksa, why are you bothered? It's just a 2% increase. What happens to 2% here or there? Don't be too fussy. So then we check the mean glucose, the average glucose. This is done by calculation. It's a very simple formula. And when you explain to your patient, let us say patient comes with HbA1c of 9, and then I tell her, Madam, your average sugar is actually 212. Had we done your glucose 1,000 times over the past 3 years, average would have come to 212. This includes fasting and PP both. And the normal, that is what is given in the lab report, the normal is 116 for this. So see 212 on one hand, 116 on the other. Your glucose is twice as high. Madam, it is 100 times more. It is 100% more. So this number actually helps create a sense of urgency, severity, seriousness in the patient. Same thing I've seen with blood urea and serum creatinine. Now, the textbook tells us to do serum creatinine and to calculate EGFR. I do that. But if you want to get the patient moving to accept a RAS blocker, even if the patient is normotensive, to accept a statin, for example, to get the blood pressure lower slightly more, then the blood urea number is more powerful than the serum creatinine number. EGFR numbers are also more powerful because they tell the patient how close the patient is sliding to CKD stage 4 or 5. If you are able to do CGM and AGM and calculate time in range, you can also tell your patient that we are doing this time in range not only to give you a number or to ensure that you are in the safe zone, in the Goldilocks zone. Time in range is meant for today. It is also meant for tomorrow, because if you are out of range, the risk of microvascular complications will go up. We also, with some patients, introduce the Goldilocks concept. So Goldilocks was a little girl who went into the forest and she entered a house. And this is a story that we've all read in school. She sat in one chair, it was too big. The next chair, it was too small. The third chair was just right. So time in range should be just right. It should not be too much, too little. There should be no hypo, no hyperglycemia. And if you use the word Goldilocks hormone for insulin, Goldilocks chemical for glucose or time in range, many patients resonate with this. They understand this. This is how a picture will look of ambulatory glucose monitoring. Now, usually we do not take names of companies, but allow me to say here, because there's just basically one provider. For continuous glucose monitoring, the best provider is Medtronic. And for AGP, ambulatory glucose monitoring, it is Abbott. So you should try these out. If you've never used either of them, it would be a good idea to start with AGP first. This is more patient friendly, more physician friendly as well. And you can see from the pictures in front of you, you can very easily explain to your patient. See, much of the time you are in green zone, but sometimes you are going into orange and pink. That is too high. And there are times at night, see, from roughly 2 a.m. to roughly 9 a.m., that you are in hypoglycemia. This can be life threatening. So we need to reduce your nighttime dose of insulin or glimepiride. We also see that the glucose variability is very high. It is 45.5% in these 14 days. So that means there is something wrong. Either our diet is variable, our physical activity is variable, or maybe we are not taking the right regimen, the right pharmacological regimen. Maybe our insulins have a high coefficient of variability. So we might want to shift from human insulin to insulin analogs. And had this patient been on insulin, certainly there would be a strong case to shift this patient to analogs. Had this patient been on sulfonylureas, there would be a strong case to reduce the nighttime dose of the dinner dose of sulfonylurea. What targets do we need? We should be aware of these as well. For most people, we would want to target less than 7%, less than 7, without significant hypoglycemia. You can also count time in range. For most people, the goal would be more than 70%. So easy to remember, 7% HbA1c, 70% time in range. Less than 7 HbA1c, more than 70 time in range. Another 7 that I remember now, which was taught to me by Professor Sarita Bajaj from Prayagraj, that is the definition of severe anemia. So WHO says HB less than 7, severe anemia. Time below range should be less than 4%, and time in severe hypoglycemia, that is less than 54, should be less than 1%. So we must avoid hypoglycemia at all costs. If there is no hypoglycemia, patient is able to tolerate well, we are very happy going down to an HbA1c of 5.5, 6, 6.5. The Japanese and American endocrinology guidelines actually ask for us to go down to 6.5. Earlier, we did not have safe drugs. We did not have good diagnostics, monitoring techniques. That is why we were not able to achieve target. But now we have better drugs, safer drugs, and more effective monitoring devices. So we can try to achieve a lower HbA1c. This will be better in the long run. How do you change therapy? You will change according to the spectrum of disease, according to the severity of symptoms, according to what is significant for the patient, and according to swiftness of change. Let me try to explain. Suppose HbA1c was 11. After 3 months, it has come down to 7 or maybe 6.5. That is a very swift change. I will reduce my medication. But if 6 months ago the HbA1c was 8, then it came down to 7.5, and then now it is 6.9. That is a very slow change. I will continue the same medication. I will not change. So that is about swiftness. Let's talk about symptoms and severity of symptoms. Are there symptoms of hypoglycemia? Symptoms suggestive of hypoglycemia? If yes, we will de-escalate therapy. If there are no symptoms, patient says he or she is fine, there is no microvascular complication, no autonomic neuropathy, no concern about hypoglycemia unawareness, we will continue the same medication, even if HbA1c is 6.2 or 5.8. Let us talk about what is significant for the patient. Patient says, doctor, I don't mind taking an extra tablet. I just want to be healthy and I want to dance at my grandson's wedding 20 years from now. Then we will continue. But if patient says, doctor, there are so many tablets, I am sick and tired, please reduce some, then you might want to reduce a tablet if the A1C is below 6.5. So it depends upon what is significant for the patient. The first S was spectrum. If there are lots and lots of acute illnesses which will benefit from lower HbA1c, maybe tuberculosis, maybe diabetic foot, asthenia, then we will continue the medication. If there are lots of chronic diseases like nephropathy, autonomic neuropathy, which may potentially lead to hypoglycemia, then we will reduce our doses. So the stringency of goals will be defined by the spectrum of complaints, the specific symptoms, the significance to the patient, and the swiftness with which we are achieving our goals. In senior citizens, in silver citizens with limited life expectancy, then again, we might want to relax our goals and we might want to de-intensify therapy. But overall, it's an individualized approach, and you must share this with your patient whenever you are discussing targets. This simple tool helps us understand what to do. Let us look at it from a biopsychosocial perspective. If your patient is at high risk of hypoglycemia, patient has a long duration of diabetes and a short life expectancy, and patient has important chronic comorbidities, specifically nephropathy, retinopathy, autonomic neuropathy, then we will go slow. We will have less stringent targets. These are all biomedical. But now look at psychosocial, patient preference, that is psychological, and social, what are the resources and what are the support systems that the patient enjoys. If these are not available, then we will go slow. We will have a relaxed target. But if our patient is highly motivated, able to take care of himself or herself, and has access to good support systems within the family, within the community, then we can be more aggressive. So each patient is different. Now, HbA1c will come later, that will come after 3 months. But before that, we check glucose levels. So in general, we would want to keep pre-meal glucose levels between 80 and 130 and post-meal below 180. In non-pregnant individuals, check post-meal after 2 hours. In pregnant individuals, you can check at 1 hour also. So we've discussed a lot about these things, and I hope I've been able to put into perspective what the glycemic targets are and how we can achieve them. And for each patient, we will have a different style, a different approach. But some things remain the same. And let us talk about a googly question which we had last week. The googly was about GLP-1 RA and CV benefit. Now, cardiovascular benefit is seen with liraglutide with injectable semaglutide. If you do a meta-analysis, you will see cardiovascular benefit with a oral and injectable semaglutide together when the statistics are taken together. But for lixisenatide and for exenatide, there is no cardiovascular benefit. There is only cardiovascular safety. So that was the googly in last week's question. But today there is no googly. So our question is, which of the following statements is correct about hypoglycemia? A, for the conscious individual with a glucose less than 96, approximately 15 to 20 gram of glucose is the preferred treatment. B, for the conscious individual with a glucose less than 70, approximately 15 to 20 grams of glucose is the preferred treatment. And C, occurrence and risk for hypoglycemia should be reviewed every 3 months and investigated. You must investigate about why hypo occurred and what is the risk of future hypo. So which of the following is correct? A, approximately 15 to 20 gram glucose is preferred treatment for person with glucose less than 96. B, it is the preferred treatment for conscious individual with glucose less than 70. And C, occurrence and risk for hypoglycemia should be reviewed every 3 months and investigated. Question 2. This one is simple. Which of these methods are used for glycemic assessment? Time in range, glucose monitoring, glucose management indicator, or all of the above? Which of these methods are used for assessment of glucose? Time in range, glucose monitoring, glucose management indicator, or D, all of the above? So with this, we come to the end of our talk and lots of questions coming in. Let me take them one by one. Dr. Vinay Desai asks how much maximum dose of glargine can be given. So what I do is I have a threshold. If I'm crossing 0.2 units per kg body weight of glargine in basal insulin, if I'm giving only basal, I will think twice before increasing. Why do I have to increase? So zero point 0.2 units means suppose my patient is 80 kg heavy. If I cross 16 units, I will just think for a minute, am I missing something or not? But if I reach zero point 0.5 units per kg body weight and there's no good glucose control, that means in 80 kg heavy man, I have reached 40 units. Then it means my choice of regimen is wrong. I would be better off shifting to premixed insulin. So 40 units of glargine is not working, but 20 units twice a day of premixed will work. Also, if glargine does not lead to achievement of target, it is possible that other drugs, other basal insulins may lead. So if there is inadequacy of glargine U100, you can always try degludec or glargine U300. You can try an ultra long acting insulin. So to answer the question once again, in general, do not go beyond zero point 0.5 unit per kg body weight. Okay, and Dr. Gangadhar Rath asks, what is the rationale to measure HbA1c every month as done by certain people, as red cell lifespan is 3 months? So the answer we already discussed, because 50% of the weightage comes from the previous 28 days of the red cell life also. And in the Japanese recommendations, they actually do HbA1c every month. And in my practice, I do it every month or every 6 weeks in pregnancy. And also in some patients where I'm expecting or anticipating swift control, rapid control. You can also do serum fructosamine. Serum fructosamine will give glucose values for the past 3 weeks, but it is more expensive and it has not been studied so robustly as HbA1c has. Another question is, we had discussed this, Dr. Gangadhar Rath again asks, which is better, 1 hour PP or 2 hour PP glucose? So in non-pregnant individuals, it is quite clear, 2 hour postprandial glucose has a stronger correlation with long-term cardiovascular outcomes as compared to 1 hour PPG. So therefore, 2 hour PPG is recommended. In pregnancy, there is confusion actually. Some people suggest 1 hour, others suggest 1 hour and 2 hour both. So that can be done. Very few people will speak for 2 hours. And again, the reason is that the 1 hour PPG has been shown to have stronger correlation with pregnancy outcomes. Third question, very important, which is more reliable, capillary or venous glucose? So now the glucometers that we have are of very good quality, and they will give you a glucose value with at the most 15% uh, coefficient of variation. So which means if I check the capillary glucose from the same person at the same time, there might be a 15% variation. This is allowed by FDA. With venous glucose, the problem is that if you test it immediately, that's fine. Otherwise, with every hour, whether you have put sodium fluoride in the tube or not, the glucose levels begin to go down because the RBCs use up the glucose for their metabolism. So if you take a sample early morning and you test it in the lab after 5 or 6 hours, the glucose level will come low, artificially low. Till last year, the WHO said that diagnosis of diabetes should be done on venous glucose and monitoring of diabetes can be done using capillary glucose. But last year in their guidelines on cardiology, Heart D guidelines, WHO has said that you can use glucometer, capillary glucose, to diagnose diabetes as well. They give a caveat. The levels for fasting glucose are the same, 100 for pre-diabetes, 126 for diabetes. But for post-load glucose, it is 140 for impaired glucose tolerance and 220 for diagnosing diabetes. So you can use capillary glucose, that is a glucometer. Do remember that you should use a good company glucometer. Use a company that is based in India, that is able to provide after-sales service to you and to your patients. One more question coming from Dr. Subhash. When HbA1c is above normal level, around 6.5 to 7.5, and fasting and PP never crossed 125, this is very common, Doctor. So in India, what we find is that if you do only HbA1c, you will end up overdiagnosing diabetes. So if it is above 7, we should treat. The treatment of choice will be metformin. You can also consider metformin plus gliptin, metformin plus vildagliptin, metformin plus sitagliptin, or metformin plus linagliptin. Give 1 tablet at night. The fasting glucose will come down. How frequently will we advise glucose monitoring? Once a week, once in 2 weeks should suffice, not more than that. How do we explain to the patient? Number one, this is common in India, especially in persons with anemia. Number two, the daytime glucose is linked more robustly with our daily lifestyle. So, if I'm following a good diet, I'm exercising in a healthy manner, I am managing my stress properly, my daytime glucose will get controlled very well. But the fasting glucose comes from the liver. It is not so strongly linked to daytime behavior. There are some exceptions. People who drink a lot at night, a lot of alcohol, people who have shift duties, people who are not able to sleep properly, people with obstructive sleep apnea. These are people where the fasting will be relatively higher. Otherwise, fasting is high because it is coming from the liver. The gluconeogenesis is occurring in the liver, and it is a reflex mechanism. It is an adaptive mechanism. So, once again, to answer the question, we will start metformin or metformin plus Vildalina sitagliptin. We will check fasting glucose once a week, once in 2 weeks should suffice. And HbA1c we can do after 3 months. Dr. Vinay Desai points out if CGM and ambulatory glucose are so good, should we do them continuously? So, some people actually do it. They do it continuously. The ones with type 1 diabetes, and in UK, many people with type 2 diabetes do it continuously. In India, what most people do is they tell the patient every 3 months, you get an ambulatory glucose monitoring done. So that will tell you about the glucose profile, the glucophenotype over 2 weeks, and it will also give you a calculated value of time in range and HbA1c. Dr. Shashi Khare says, with alcohol, can we prescribe gliptin? Yes, overall it is safe. If the SGOT-PT are up till about 2 times or 2.5 times normal, you can prescribe gliptins. If it is more than that, it would be better to avoid, shift to insulin. The safest gliptin from a liver point of view would be linagliptin, because linagliptin has got a dual mechanism of excretion. The liver and the kidney both can excrete it. The one where you would worry about the liver would be vildagliptin. But that is just a relative statement, not that it should not be prescribed. And Dr. Shashi also says, can we prescribe insulin to individuals who are wet controlled for S2 pancreas? Answer is yes. There is no contraindication for insulin, provided that you give the right dose. So, in which patients would I advise insulin? Even when the glucose levels are not very high. These are the catabolic patients. Patients who are lean, thin, marasmic, they are looking malnourished to me. They want to gain weight. Their BMI is on the lower side. It is about 18, 19. In such patients, I'll give insulin. Patients who are complaining of asthenia, energy, there is no other reason. I'm not able to find a reason for their lack of energy. Again, I can prescribe insulin, small doses, because insulin is the most potent anabolic hormone in the human body. Dr. Suresh Pawar also points out that 2 hour breakfast and 2 hour lunch both have their own value. So ideally, both should be done. Uh, Sometimes it is not possible for us to do a 2 hour lunch, but still we should encourage the patient to do it. Alone 2 hour lunch, post lunch will not help. It would be a good idea to do a paired glucose testing immediately before lunch and 2 hours after lunch. That will tell us about the jump that we see, the excursion that we see. I would also like to give a call out and to welcome Dr. Altaf Chima from Lahore in Pakistan. Salam, Dr. Sahab, and thank you for being with us. Dr. Chima is one of the leading diabetologists of Punjab province in Pakistan, and it is good to have him with us. Dr. Rajdeep Biswas says, what is the cutoff blood glucose for cataract? So, again, uh, fasting should be around 100-ish, and postprandial should be between 140 and 180. Wait for a couple of weeks. If, let us say, the HbA1c is 12.6, you've been able to control glucose within a week. Do note that a lot of changes are occurring in the patient's lens and in the patient's retina. So wait for a few weeks for the glucose to stabilize. Don't be in a hurry. How do we explain to our patients? What I tell them is that in your eye, you have a lens. The lens is like a raisin, kishmish ka dana. And the best raisins we get from Afghanistan, from our friends there. So now, if your sugar is 14%, 15%, it means it's a very swollen raisin. You're going to see differently. Even if you go and get your spectacles made, these spectacles will not work after 2 weeks, because after 2 weeks we will have brought your HbA1c down. The swelling in that resin, in that lens, will have come down. The water retention will have come down if we control glucose. How do we explain water retention? So what we say, madam, supposing by mistake you drop some sugar or some salt in your kitchen, what will happen? Both of these are hygroscopic. They will attract water. So that is why the lens is swollen. Same for retina. So when the glucose comes down and it stays stable for a short period of time, that is when we can deal with the cataract or with the retina. Also note that if you are too fast in controlling glucose, you might actually end up worsening retinopathy for a short period of time. Dr. Manjeet Sangwan raises a tough question. In patients with type 2 diabetes and hypertension and coronary artery disease, how to deal with glucose control? So we give whatever drugs are available, but if it is coronary artery disease, we will avoid pioglitazone. We will preferentially use two classes of drugs, SGLT2 inhibitors and GLP-1RA. SGLT2 inhibitors now are actually indicated even in patients with CAD without diabetes. So unless there is a contraindication or unless patient is not able to tolerate because of genital infection, we must give uh, empagliflozin. If there is established coronary artery disease, the drug of choice is empagliflozin. Other alternatives would be dapagliflozin and canagliflozin. If glucose control is not achieved with that, you've given metformin, you've given empagliflozin, then you might wish to add a sulfonylurea or preferably add an GLP-1 receptor agonist. Last week, we had spoken about person-centered choice of GLP-1RA. Let me repeat. If patient is willing to take injection daily, if patient has established CAD, wants risk reduction for ASCVD, if patient wants weight loss, then injectable liraglutide is the first choice. If patient doesn't want to take injection every day, but is fine taking once a week, then we can give dulaglutide, that is a once a week injection. If patient doesn't want to take injection at all and is happy taking a tablet, then we will give oral semaglutide. Oral semaglutide must be given 30 to 60 minutes before breakfast and with a maximum of 120 ml of water. In Pakistan, we also have injectable semaglutide, that is once a week. That would be a very good drug of choice. It is not available in India as of now, but that would be the drug of choice if someone has CAD, someone wants to reduce CV risk, and someone wants to reduce weight as well. Then once a week injection semaglutide would be the first choice. So thank you, Dr. Manjeet, for raising these questions. They help us all think beyond the normal and beyond the routine. Dr. Vishal Mutkle says, "What do I think about Remo, Metformin, and Vilda?" So I have never used it, Vishal. The reason is that remogliflozin is not backed by data, and when we have dapagliflozin, empagliflozin, and canagliflozin, which are backed by data, then it is difficult to justify using Remo. When the data comes, then maybe I will use. But when it comes to just triple combination of metformin, SGLT2 inhibitor, and DPP4, this is welcome. We should use these. They will help in achieving safe glucose control without increasing weight. So I would strongly recommend a combination of uh, Cana or DAPA or empagliflozin plus metformin plus Vilda or Sita or linagliptin. Dr. Vinay raises a case scenario, HbA1c 5.7 perfect, BMI 18, pre-diabetic. Don't worry about that at all. Age 54. Just continue with whatever you're doing, Doctor. There is a family history. Uh, the aim is to prevent heart disease. So just look at your lipid profile and you can do something called Q risk 3. Q R, both in capital, then ISK, Q risk 3. You go on this website. This is from United Kingdom. You can enter all this data that you put, and you also enter your nationality: Indian, Pakistani, Bangladeshi, other Asian, and you will get your CV risk for the next 10 years. If you feel the CV risk is on the higher side, then we will start a statin, atorvastatin or rosuvastatin. Dr. Yogesh Poke says, how will we manage fasting glucose by premixed insulin? We can do that, but we have to use it either twice a day with breakfast and dinner, or maybe once a day with dinner alone. In premixed insulin, 70% of the total insulin is long acting or intermediate acting, so it will help control fasting. We can use the insulin analogs. We have biphasic aspart 3070. We also have biphasic Lispro or Lispromix 2575. Both are good. But even if you are not able to achieve good fasting glucose, then the drug of choice will be a co-formulation. IDEG asp, degludec plus aspart. This has 30% aspart, which will control the post-dinner, and 70% degludec, which will control the fasting. And you will get good results. Dr. Deepak raises an important question. In hypoglycemia episode, how many days exactly should patient refrain from insulin or OHA? Thank you, sir, for raising this question. So it depends upon the half-life of the insulin. Suppose someone got hypo due to degludec or glargine U300, then we should wait for at least 4 or 5 days. If it was due to glargine U100 or NPH insulin, we will wait for about 2 days maybe. If it was glimepiride or glyclazide, these are long acting, again we will wait for 4 to 5 days. If it was repaglinide or acarbose, we can start the next day. And Dr. Vishal points out this is true, Daksab, especially in summer. After starting SGLT2 inhibitors, patients begin to complain of fatigue. Tell them to increase their electrolyte intake. Enerzal zero is a nice way of doing that. But if even after a week or 2 weeks patients are complaining of fatigue, we can stop the drug. So you explain to them that the drug is helping drain all the poison from the body. That is how we will explain. But with the poison, it is possible that some good things also might have drained out. So just focus on your diet, small frequent meals, and ensure good electrolyte intake, especially during summer. It will be more common in these 2 months, Dr. Vishal, because of heat exhaustion. So just encourage them to take homemade drinks like kokum juice or lassi, buttermilk, jaljeera, and also the medical grade drinks, beverages like Enerzal Zero. So I hope I've been able to answer the questions. It was always good to take these comments and questions because, like I said, it helps us all stimulate ourselves and each other. And finally, we are all united in our aim. And that aim is a very happy and healthy world, a happy India, a healthy India, an India where no one has to suffer from complications of diabetes. So I'd like to leave you with that and back to Team FDC.
So I think already taken 43 minutes of long list of questions of all our viewers. That shows that how important and how impactful your presence every Sunday on this platform. Because I personally, when I met the doctors who have been regularly watching our show every night at 9 p.m., they simply say that because Dr. Sanjay Kalra is there on every Sunday, whatever and whenever there is any difficulty individually, when we have in terms of treating a patient, we know that every Sunday he will take all our questions. That's the confidence they have, sir. And I'm telling you, sir, the uh, kind of good work you are doing in terms of improving their clinical ability to treat a patient in India, because the number of people who are getting updated on a Sunday basis is huge. And because I see a trend. The technology in our days, people used to have only lab-based assessment. Now they have got glucometers. Now they have got continuous and AGM monitoring. So updation on the basis of targets and the way they want to be treated. That's how they are actually graduating from their day of practice to the modern day of practice, and that is only because of you, sir. Thank you very much, and I once again congratulate all the viewers to be with us. And I think this is sixth or seventh episode, and we are now optimizing the numbers. Every week I am counting the numbers, and I think we are now reaching to optimization, sir. Thank you, sir. Good night. Jai Hind.
Jai Hind.